Thank you for coming. All right. Thank you for coming. Good morning, good afternoon, good evening, depending on where you are. We have a very international audience with us tonight, and I'm very happy to see you all here with us tonight. This is the second in the series of English language NeuronUP Academies, which are for professionals and students working in the field of cognitive sciences and cognitive health. My name is Brian. I work here at NeuronUP. We are the leading cognitive stimulation platform for professionals. We created NeuronUP Academy with the idea that professionals expand and share their knowledge in the field of rehabilitation and cognitive stimulation. Today we have a treat because this session will have not just one, but two speakers with whom we have the pleasure to spend this informative hour. Dr. Amy Rosenbaum and Dr. Keith Ganci have joined forces to give us their presentation. Tonight's presentation is entitled Considerations Based on Impairment Severity and Treatment Setting. Sorry, I read it wrong. Clinical Application of Evidence-Based Cognitive Rehabilitation Strategies. Considerations based on impairment severity and treatment setting. So before introducing our esteemed guests and getting on with the presentation, I would first like to share a short video about NeuronUP so that those of you that don't know us can learn a little bit about us.
¿Resuelven estas situaciones en tu trabajo? Horas navegando por internet y peleándote con el ordenador.
That's in Spanish, my bad. One second. Bear with me, sorry.
Do these work situations sound familiar? Hours surfing the internet and struggling with your computer? Tons of material to sift through and organize, yet finding the same activities over and over. Doubts about which materials to use for follow-up? Do you imagine personalizing exercises so they are just right for each individual? Would you like a simpler way to monitor progress, count on the assistance of other professionals, share ideas, and stay up to date? NeuronUP, a web platform for professionals dedicated to neurorehabilitation and cognitive stimulation. Acquired brain damage, neurodegenerative diseases, normal aging, neurodevelopmental disorders, and mental illness. Numerous materials and innovative tools, classified into over 40 cognitive processes, cataloged by difficulty, age, and mode, with a multi-format application. The treatments are adapted to each person, which favor generalization and adds greater ecological validity. NeuronUP is accessible anywhere, allowing for greater proximity to patients and the ability to design sessions so that each user can work anytime, anywhere. With NeuronUP, you can communicate with other professionals and stay current. The future of neurorehabilitation is at your fingertips. Do these work situations...
All right. Can you hear me now?
Yep.
Okay. So yeah, like I was just saying, I think you can hear me now.
Yes.
All right. So I was saying, if you could please put in the chat while I'm introducing the speakers, your occupation and any specialties that you work in. It'll give our speakers an idea of who our audience is here tonight, and it'll maybe help them guide the conversation as they go. Thank you for that. So the first of our two presenters today is Dr. Amy Rosenbaum. She has specialized in the area of brain injury rehabilitation for nearly 20 years, and she helped create Park Terrace Care Center's cognitive rehabilitation program, coma recovery, and coma management programs. And she also serves as a TBI model systems investigator for the New York TBI model system at Mount Sinai. She has published textbooks and journals, and her work has been presented nationally and internationally in subjects that include disorders of consciousness, cognitive rehabilitation, and neuropsychological assessment, just to name a few. She is currently working on various task forces within the American Congress for Rehabilitation Medicine, and she is one of the authors of the ACRM's Cognitive Rehabilitation Manual. Dr. Rosenbaum also has her own company called Brain Matters. The company's mission is to provide education, training, and support to survivors and their caregivers to improve clinical management, care outcomes, and continuity of care across the continuum of recovery. Our second speaker is Dr. Keith Ganci. Dr. Ganci will be speaking about the impact of treatment setting on the administration of cognitive rehabilitation. And throughout his career, he has had the opportunity to work in various settings, such as treating neuropsychologist on an acute inpatient unit, in a subacute facility, in a comprehensive outpatient unit, and most recently as a private practice provider. Dr. Ganci is an active member of the North Carolina and New Jersey State Psychological Associations. He, like Dr. Rosenbaum, serves on several task forces in the ACRM, as well as being a trained faculty member, and he will be one of the primary authors on the upcoming second edition of the ACRM manual and textbook. He recently was appointed to the Brain Injury Association of America's Cognitive Issue Panel to help create best practice guidelines for moderate to severe traumatic brain injuries. I want to welcome and thank them both for taking time out of their days to be with us here today. And one last thing, before we begin, please, if you could please keep the chat to a minimum. It can distract from the conversation. Drs. Rosenbaum and Dr. Ganci will be giving their presentations, and at the end we'll leave about 10 to 15 minutes for questions. As they finish, I'll let you guys know, then you guys can ask away. If you guys have tons of questions and we run out of time, we don't get some questions, I will compile those questions and send them on over to Dr. Ganci and Dr. Rosenbaum, and we will post them on the blog. That's about all I have to say. So thank you much for your time, and I will turn it over to the doctors. Thank you, guys.
So Brian, do you upload the presentation or do I do it from my screen?
I can do it right now.
Okay. Okay. How do I get back? Okay. So thanks, Brian, for that introduction. And thank you all today for showing up and being a part of this lecture. It is truly an honor to be able to reach such a broad audience and to be able to try to share knowledge to people across the world. Yet at the same time, it's a little bit of a challenge, especially when it comes to cog rehab, because so much of what we do, at least here in the United States, is completely dictated by the structure of the healthcare system that we work in, as well as the structure of the insurance payer system. So we are a little curious whether some of the challenges that we face, and as well as the structure of the healthcare system as we lay it out, is similar or different to what you guys encounter in your regions. So just to give a little bit of background for myself, I work in a subacute inpatient rehab facility, and rewind about 20 years ago to when I first started, length of stays were significantly longer than what they are now. systems of care were better and more cohesive than what they are now. There never was a clear, consistent pathway that people took, but most people would, by the time they got to us, be several months post-injury, and then would continue to receive intensive rehab from us before going back to the community, where there were transitional services in place, which are quickly dwindling. So I think the major things that are really impacting on our clinical practice at this point for me at a subacute is that we're receiving people much earlier post their injury than before, as more, especially because I treat patients with moderate to severe brain injury, and so their access to acute rehab is extremely limited. In America, we use Medicare guidelines sort of dictate what happens, and there's some wording in the Medicare guidelines that are actually misinterpreted to prevent people who are unable to follow commands at the time of hospital discharge, excludes them completely from access to acute rehab. And as Brian mentioned, one of the specialties that we have at Park Terrace is coma recovery, which means that we're receiving these patients pretty much straight from their hospital units. They may only be a few weeks post-injury. They're not medically stable the way that they should be. And at the same time, we're starting to get denials for coverage for treatment after a couple of weeks, meaning that there's a much greater pressure on us to move the needle faster to getting people to independence and safety than we'd ever been operating within before. So some of these changes are behind the impetus for the American Congress of Rehabilitation Medicine's Evidence-Based Cognitive Rehabilitation Manual. This manual was put out by ACRM, who has a subsidiary of ACRM is the Brain Injury Special Interest Groups, of which there's a Cognitive Rehabilitation Task Force, which over many years had conducted several systematic reviews of the literature on cog rehab interventions. And out of those evidence-based reviews came practice recommendations, but there still wasn't enough to give the clinicians the information that they needed in order to carry out those treatments. And so the goal was really to compile in one easily accessible place all the information that clinicians would need in order to effectively carry out the interventions that were recommended in the reviews. So we're currently in the process of trying to complete the second edition of the textbook, which has been expanded to not only serve as a manual for clinics and practical reasons, but also to serve as a university textbook, and will also be an online resource. And this manual will also integrate the results of the latest review, which is currently also in the process of being published, and those updated recommendations as well. So one hope is that it would impact reimbursement in some way, being able to justify that if you're providing evidence-based practice, just like with any other medical discipline, that we should get reimbursement for it. But I think a broader mission is here in the United States, cognitive rehabilitation is really not considered a discipline independent from OT and speech therapy. And those of us who provide cog rehab in the field do view it that way, but when you're talking to insurance companies and many programs, the way that they're structured really don't isolate cog rehab out as a separate discipline. So the goal is to try to add more legitimacy to the field as a whole, to try to make us more systematic and efficient in our practice, and to be able to build in by having goal-directed treatments, issues with, I'm sorry, I'm hearing, I don't know if Brian could still hear, but it looks like the sound is cutting in and out. So if you can work on that while I continue to try not to get distracted by that, that would be great. But anyway, so to try to make things as efficient as possible so that we could also systematically monitor our outcomes and patients' responses to treatment. So these are the learning objectives for today, which essentially are centered around understanding the impact that injury severity, that impairment severity and treatment setting can impact on decision-making across the board, from selecting your treatments to how treatments are implemented, and to hopefully walk away with some strategies in order to create individualized interventions in light of these factors. The focus is not going to be on carrying out the interventions per se, so much as it is talking about the broader treatment planning process and the factors that go into play in designing individualized treatments for patients. So the manual is set up, divided into chapters. And so there's a chapter dedicated to 5 different common areas of cognitive impairment. There's a chapter dedicated to attention, memory, executive functioning, visual spatial functioning, and social communication. And each chapter has the recommendations for that area, followed by the specific guidelines for how to carry out each of the evidence-based interventions for that domain. But the reality is, as many of us know, that you're never really going to be seeing a patient who literally presents with just a single impairment. Cognitive impairments happens in clusters and not really in isolation. So it's first helpful to just take a step back to look at how cognitive impairments in general impact on the functional recovery process after brain injury. And it's unfortunate that too often people think of success after a brain injury in terms of the physical aspects, in terms of the number of feet ambulated or the amount of physical support that was needed in order to perform a task. And this goes from insurance companies, obviously, as a number one person, but in a close second are the patients themselves, as well as their loved ones, who really are not understanding the role of the cognitive piece in impacting their ability to do those motor tasks. And bigger than that, especially when it comes to patients with severe cognitive impairments, there's a lack of understanding or appreciation that even if the patient was physically able to do so, that sometimes actually makes them more unsafe and increases the supervision need, doesn't decrease it. So I can't tell you how many times I've spoken to medical directors trying to get more time for a patient and explaining to them that, yes, even though they walk 50 feet, which is considered household ambulation, they don't know, they can't do anything for themselves. They don't know their daily routine. They can't take their medication. They're unaware of the fact that they still have balance issues and that they can't safely toilet themselves. They can't cook. They can't do anything. They require 24/7. And the insurance company will consistently spit back to us, well, that's custodial care. That's essentially babysitting. And that is not justifiable to keep a patient in an intensive program. But that's looking at such a small piece. That would be a fine attitude if you were treating a 90-year-old dementia patient where the expectation is they're going to continue to require that level of care. But how about a patient who was 25 years old, who now came in less than 3 months post their injury, who started out in a coma, and within that 3 months has made a miraculous recovery to even be able to achieve walking 50 feet, and then has tremendous potential to keep going from there, to get back to their life. And if you cut off the cog piece of their services early on, this could make it break the decision as to whether this person can return to the community or whether they get stuck in a long-term care facility for the rest of their days. So it is a bigger issue as far as the bigger picture and the healthcare, and the cost of from a societal level of not incorporating treatments to address cog impairments. So for patients who are at the very severe level, you're talking about people who typically don't understand what is happening. They don't know what impairments they've sustained as a result of their injury. They can't pay attention. They don't follow directions well. They have poor judgment. They engage in unsafe behaviors. They're at risk of trying to run out of the facility or run out of the home. And so the thrust of rehab is really primarily aimed at improving awareness and understanding of what has happened, improving basic cognitive abilities, like just to basically sustain attention and be able to benefit from more rote automatic tasks in order to be able to not necessarily relearn complex new compensatory strategies, but to relearn the typical daily rote activities of their daily life. So they may still require supervision in the end, but they can at least require less physical assistance and a greater level of safety and independence in performing daily routines and everyday tasks. So if we think of the focus for patients who are on the more severe end of the spectrum as they're trying to get back to the basics, we could think of the view of patients who are more mildly impaired as back to life. So here, patients who have more mild impairments are more likely to have some level of appreciation of their impairments and the functional implications of it. They're more likely to have emotional and behavioral adjustment issues as they try to cope with losses in their ability to resume fully their previous life roles. Sometimes people try to go back to work and may try to go back to work too quickly, or even if it's after a period of time, still cannot sustain a full workload or a full work schedule. They may be fatigued easily, get irritable, behavioral and emotional regulation problems are common at this level and can significantly impact on both the ability to hold down a job as well as to establish and maintain healthy relationships with their loved ones, which could obviously significantly impact on not just their quality of life, but the quality of life of all the people in their life. So here, the focus is on trying to help people find ways of managing their symptoms, of coping with the emotional, interpersonal, and behavioral aspects of recovery, on promoting increased productivity, the ability to fully resume previous life roles. And even if they're being treated in an inpatient setting, these are the patients who are learning compensatory strategies to maximize their ability to independently carry out their instrumental activities of daily living. Things like doing their laundry, their cooking, paying their bills, and community reentry tasks. And so again, here the focus is more on getting back to their life and back to some semblance of independence, not just supported independence. So moving on to the recommendations. I'm not sure how many of you are familiar with the evidence-based reviews that have been published by the ISIG task force or the manual itself, but this is just to provide you an orientation very quickly to the idea that not all of the recommendations in the manual are created equal. And they come out of what we would consider fairly standard ways of applying evidence to creation of practice guidelines, and that is that all the evidence that's available on a particular domain is evaluated based on the number of studies for a particular treatment as well as the quality of those studies. And I won't get into the details, they're here on this slide as to how the different guidelines are graded, but the key take home here is that there are 3 levels of recommendation, each distinguished based on the level of evidence to support their use. And so in the manual where you see things labeled as practice standards, those are the recommendations that are offered with the highest level of confidence, and because they have enough evidence to show that it is substantial evidence of effectiveness, and so those are basically interventions that should be applied whenever appropriate. At the next level are those interventions that have shown evidence for probable effectiveness, and on the lower level is those that have shown evidence of possible effectiveness, but the class of the studies that were included for that option were not strong enough, and more research is needed to strengthen the recommendation.
And Amy, Dr. Rosenbaum, sorry, if I could jump in.
Sure.
Real quick there too, just there has been a push, I think, throughout the course of the last couple of systematic reviews that very well designed class 3 studies or single case studies are starting to get a little bit more credence. So just for any folks that are not associated with a hospital system or may not have the capacity to do RCT1s, we are starting to look at single case studies more and providing a little bit more weight to those, considering that if they are well designed and if they're showing a positive effect.
Yeah, and I think along those lines, there is an increased thrust in the second edition of the manual, which is coming out on the application of single case methodology to treatment, whether the intention is to eventually publish outcomes or not. That one important direction that we need to move to is to recognizing that it's not easy to find samples to study in this population, and we don't want that to sort of preclude the field moving forward. And so even if you're dealing with a single case study and it's a repeated baseline or you have the data to support your use, then on a case-by-case basis, that's more effective, and even on a more global basis, as Dr. Ganci said, we will be taking those into consideration in future reviews. So just to look a little bit now at the recommendations that are in the book, this is just a sampling to show you that within each domain, and here is just executive functioning and memory, but every domain pretty much is the same, that there are multiple recommendations within each deficit area. And those are distinguished, as we said on the last slide, by the level of the evidence. So you see this practice standards, options, guidelines here. But the other thing to point out is that it also within the recommendation wording itself often, not always, but often indicates who it's more appropriate for with respect to level of severity. So in a purely black and white world, the simplest way to approach would be if you wanted to handle a deficit in executive functioning, you would go, and then logic would dictate that you should select the treatment that has the most evidence to support it, which would be the practice standard. But as you see, for both memory and executive functioning, the practice standard is only applicable for patients who have mild impairments. And so when you have individuals who have more severe impairments, sometimes there's an unfortunate process of elimination that limits the options that are available to address that. I just want to take a second to make a distinction between what we mean by, sorry, that's the wrong direction, what we mean by injury severity versus impairment severities, because injury severity, which we would gauge by, say, initial GCS score or duration of loss of consciousness or duration of post-traumatic amnesia, is sometimes, but not always, predictive of the extent of cognitive impairment. And there are plenty of individuals who have very severe have very severe injuries who later go on to make remarkable recoveries with very limited or very few residual cognitive impairments, and those who have more mild injuries who end up going on to experience more long-term chronic debilitating impairments. And so when it comes to clinical decision-making and treatment planning, it's really what we would consider the collective cognitive impairment profile, as well as the functional impairments that are being exhibited, that really drive decisions and treatment planning, treatment selection, more so than injury severity itself, which in isolation doesn't really give much information. So in moving a little bit more detail into the treatment selection process, as we saw, if you were looking at a single impairment area, we already discussed that some of the information is cut and dry in the recommendations themselves. But as we also said, impairments don't happen in isolation, and so it's not realistic to think that you're going to have a picture-perfect patient who comes in with an isolated impairment in attention, and then you can go to those recommendations and select from there. It's really about understanding the patient's entire profile and taking all of that information together in order to create the most individualized and appropriate treatment for your specific patient, which may be very different than the next patient who has the same combination of deficits but might have differences in respect to their areas of preserved functioning or their functional impairments. So there are no evidence-based guidelines to support this, but we do have recommendations that come out of the authors of the manual's collective clinical experience, and so that's what we offer you today. So at first, we would say that whenever possible, it's not always feasible, to the extent possible, that COG rehab should always begin with a comprehensive assessment of the individual's impairments as well as their relative strengths or areas of preserved functioning. So even within a single area of impairment, let's take memory, for example, you may know that there's a memory impairment, but you still need to understand the nature of the memory impairment as the next level of decision making. So is it that the problem is with verbal memory or visual memory? If it's with verbal memory, is it difficulty remembering to do things or remembering events, or is it difficulty remembering information? Along the same lines is, what is the functional task that's related to this impairment? So is it a student who needs to be able to study from a textbook in order to graduate or get his GED? Or is it a homemaker who needs to be cued to remember to carry out their daily routines, to remember the chores they need to do for the day, and or to remember items on a shopping list at the store? On the flip side, I think we spend a lot of time understanding and focusing on isolating and identifying the impairments and don't always think about the other side of it, which is what are the areas of preserved functioning, which everybody has, no matter how many areas are challenged. There's usually at least a few areas of strength that can be tapped into and used to help support teaching compensatory strategies. So in talking about using external aids, many young people are very tech savvy. They've been using computers, iPads, smartphones from the time they were literally able to walk. And so for them, even if after their brain injury, they're in a confusional state and they don't remember how to use it, it's still going to be much quicker and easier for them to relearn that previously automatic skill than it would be, say, for an elderly patient who never learned how to use a computer before their injury, in which case it's not going to be realistic. Regardless of how useful a smartphone could be for compensating, it's not going to be a useful strategy for somebody who's older and not comfortable using a computer. Along the same lines, if a person has an impairment in visual memory, but verbal memory is a strength, you could use verbal types of memory strategies to help support, and vice versa. Finally, we talked about severity of the individual impairment impacting that process of elimination as you look through the recommendations, but it's not just the impairment of the single area, it's taking into consideration what is the nature, extent, and range of their collective impairments. So to me, I think this is the most challenging part of for a new cognitive retrainer to really figure out, because ultimately, as we've been saying, these things don't happen in isolation. If you have a traumatic brain injury, you could really have any particular combination. But for me, in my experience, there's certain impairments that tend to go together. And the one I like to use as an example is what I call the trifecta of attention, memory, and executive functioning impairment. It's because even in a healthy brain, those three skills are so interconnected that it's more common than not that if there's an impairment in one of those domains, that there's going to be an associated impairment in one or both of the other domains. And that particular trifecta is relevant because that combined impairment plays a big role in determining a patient's responsiveness to rehab efforts, to their ability to be able to learn and remember, their ability to independently use compensatory strategies, and essentially ultimately impact on their capacity for independence. And so what do you do when you have all three of those and say, again, now we're talking about the confines of our healthcare system, you've got maybe a couple of months in an inpatient setting to address them? There's a few options. So number one is within the manual, there are some treatments that are specifically targeted to incorporate or enlist a number of different cognitive abilities without individually isolating any of them. So for example, the co-op treatment within an executive functioning section engages memory, executive functioning, and attention on tasks that would collectively engage that, because in real life, we don't, tasks involve multiple domains. And so they don't specifically individually treat, but the mission is to collectively improve those areas through this one targeted treatment. There's also comprehensive multimodal computer-based programs, which also allow you to target multiple areas. But beyond that, what's more common is really just taking a rational, goal thought out approach to deciding what goes hand in hand with each other. And again, some general guidelines to consider are prioritizing. Think about the hierarchy. If a patient has a deficit in awareness that needs to be addressed first, a patient who's unaware is not going to benefit from therapy. Does not matter how beautifully designed your protocol is, you won't ever move past that stage if they are resistant and don't recognize the need for the treatment. And along the same lines, if they can't pay attention, then they're not going to be able to learn. If they can't learn, they won't be able to remember or benefit from executive functioning strategies. And so some of it is a matter of, again, a process of elimination based on where the patient is breaking down and what they're capable of. But I think the bigger take-home message is that we actually encourage and think it's necessary to try to create protocols that integrate in addressing multiple deficit areas that sort of correspond to each other. And so if a patient is having trouble with attention and memory and executive functioning, but really the thought is that the problem with attention is impacting on memory, well, then it would make sense to do attention and memory together. Some of the treatments like attention process training specifically recommend that it be used in conjunction with metacognitive strategy training. So some of it is taken out of the decision-making process just by, if you choose the treatment, it may guide you. But even without that, you need to take into consideration these last two factors, which are the question of how much support, how much external direction, how much assistance is the person going to need, and ultimately, what is the broader goal or expected outcome for the patient. So just to cover off on those quickly, this is just an example of within the memory recommendations, but these recommendations are consistent across the deficit areas. And that is that, number one, regardless of the intervention that you're using, the crux of all COG rehab interventions is training in the use of strategies. And strategies can be external or internal. External strategies are things that we all use in our daily life, even without a brain injury, from the fact that I'm timing my talk right now on my phone, to the fact that the alarm was set to wake up this morning, to the fact that some of you might have programmed into your calendars a reminder to sign into this presentation at the correct time. And these are things that are external to the patient or the person that provide a greater level of assistance or cueing in order to help them perform a task. Internal strategies are teaching a person to use a self-generated cue, which might be a word, a picture, an action sequence, as a trigger to engage in a task. And so it's not surprising that for patients who are more mildly impaired, they can benefit from training in the use of both external and internal strategies. But because internal strategies require a higher level of memory, initiation, self-reflection, they're generally not appropriate for people with severe impairments. So this slide just sort of breaks down. It's not all of the interventions in the manual, but many of them just broken down by category and whether they are internal or external, just for you to have a sense that the manual sort of covers off on both. And then the last thing to take into consideration is, regardless of whether you're using internal or external strategies, regardless of whether you are treating a mild impairment or a severe impairment, and regardless of the actual program or intervention that you're using, the last question is, what are the specific tasks the patient is going to work on, and what are the goals? And again, these are things that are directly mediated by their impairment level. That helps make these determinations. So regardless of the protocol being applied, any protocol can be employed by either a broad-based approach or a task-specific approach. So if I'm using a broad-based approach, and let's say I'm using smartphone to train someone to compensate for memory deficits, the goal there would be, I'm going to teach them to set the alarms, set calendar apps, but ultimately my goal is that they're going to be able to use this phone to compensate for the entire domain of memory, so that they can use it to know their daily routines, schedule their doctor's appointments, remember when to take their medications and refill their medications, even down to remembering how to get to the pharmacy to pick up those prescriptions. And this is opposed to a task-specific approach, where it is essentially what it sounds like. You're training to the task. So I still may be using the same external strategy of training in the use of an external aid. I may be using the same method and the same tool of the smartphone. But here, I'm literally just training the patient for whatever it is I'm doing. So if I want to set alarms in there to cue the person that it's time to take their medication, with the goal that when the alarm goes off, they'll read the message and go take their medication, then that's pretty much all I'm hoping for them to do, without the expectation that it's going to independently generalize to other aspects or other apps on the phone. And so it would make sense that when appropriate, a broad-based approach is ideal, because it does facilitate more that idea of being able to get back to life. It promotes a greater level of independence. It's more likely to generalize to other tasks and settings. But again, as is the theme of this part of the talk, that's not always appropriate. And that approach is sort of deemed as more appropriate for patients with mild impairments, and as opposed to the more severe impairment, where the BIISIG recommends that a task-specific approach is more appropriate. And here the focus would be, again, on back to the basics. So just to summarize before I pass it over to Keith, is essentially the main take-home points for this piece of the talk are that the important components that need to be taken into consideration when you're selecting and designing treatments are the nature, severity, and range of their collective impairments, tying that into the functional tasks that are impacted and what the ultimate goals and expectations of treatment are, as well as treatment setting, which Dr. Ganci will talk about now. But the sort of cues to remember are, for patients with mild impairments, you want to adopt a broad-based approach using internal and external strategies, with the goal being to try to help them get back to life. For patients with more severe impairments, you're looking to take a task-specific approach with the use of only external strategies and aids, and the goal to help promote getting back to the basics. So that's the end of that piece. I'm going to pass it over to Dr. Ganci now. He'll talk more about how the treatment setting also impacts on the design and implementation of treatments.
Okay. Hi, everybody. Thank you, Dr. Rosenbaum. So we're going to talk, obviously, now this piece is going to be directed on, treatment setting and treatment level, and how that affects the administration of cognitive rehabilitation. Dr. Rosenbaum spoke about how a patient with, the same injury or the same type of injury, same mechanism, same location, could have very different cognitive profiles and cognitive impairments, and you would obviously need to adjust between those two patients based on that. I think the same applies with the treatment setting. You may have a patient that has, or two patients that have very similar cognitive profiles, but if you're treating them in different settings, you need to have consideration for that, and the treatment interventions, the monitoring of progress may change. And a reason I think that we break this down and treat them as two separate variables is, in the past, there was more of a close association between injury severity and treatment setting, because you're seeing your more moderate to severe patients in inpatient facilities, and the more mild to moderates in outpatient. And that has switched a bit. I think there's a trend where we are starting to see, at least for me as an outpatient provider now, a lot more severe patients, even patients that are very far post, and patients that are also very acute in an outpatient setting, whereas they in the past may have spent a few weeks or months or even a year inpatient before getting to us. I'm going to click here. So here are going to be the different treatment settings and levels of care that we're going to talk about. I think it's important to note that not all patients are going to necessarily progress through all of these, and certainly not progress through these in a linear fashion. In the past, I think it was more typical for a patient with a moderate to severe brain injury that they would progress through this in a linear fashion, but that, like I said, it's not always the case now. I have just kind of an example of a family friend that I would want to share. About six weeks ago, had a hemorrhagic thalamic stroke, was brought to the hospital. There was no surgical intervention needed, but it's a pretty significant injury. He was in the hospital for 72 hours and discharged home. They said that he, quote unquote, passed all the tests. He was ambulating, and they discharged him home. And he got set up to see his primary care provider and a neurologist in the community. And he did get there eventually after a few weeks. And then that neurologist set him up with a few rehab services. But he, to this date, which is 6 weeks after the injury, has not had any formal rehab to speak of. So I think this kind of speaks to a little bit of the unfortunate trend that's starting to happen now. But in looking at all these, kind of defining these, you have your acute inpatient. Those would be patients that are, have been medically stabilized, that are out of critical care, out of the trauma bay, still very medically involved. And they may be there for a few days up to a few weeks, perhaps longer in the past. And then we have patients that may not be able to be discharged home at that point, would be sent to a subacute inpatient facility, which is a step-down unit. And Dr. Rosenbaum, I know that's where you are now at Park Terrace Care Center. I wonder if there is really kind of a general or a typical length of stay, but I would think that would be somewhere in the weeks to months. But what are you seeing now?
Yeah, well, for me, like I said, when our program was actually created as a government-funded program, with the code for the program allowing us to keep patients for a minimum of 3 months to a maximum of a year. So in the past, we used to keep many patients on for a year. And like I said before, they wouldn't come to us until they were several months post. So we really were able to cover the bulk of that first year of spontaneous recovery. And now, even though our code has not changed, our regulations have not changed, our funder source have not changed, they are starting to ignore that 3-month minimum rule. And we're getting denials after like 2 or 3 weeks, sometimes even shorter. So I'd say our length of stay now is closer to 3 months, whereas, a study we published maybe a couple of years ago had our average length of stay at 10.5 months.
Right. And even that, I mean, if they're only staying for shorter amounts of time, presumably, hopefully, they are then being discharged to a comprehensive outpatient program or a brain injury specialty department. That I think is also happening a little bit less and less, where patients are also skipping past that, or they're not getting access to that level of care. And sometimes just getting these individualized, with the next phase of care, individual outpatient services. It may be part of a medical unit or a brain injury hospital department, but they may not be admitted as a program patient and get all the all the different disciplines of care. They may be seen just for PT, or they may be seen just for psychotherapy, or there's also individual outpatient providers that are not connected to any hospital unit or brain injury rehab program. And obviously there, those practitioners are working a little bit on an island. And then finally, home and community care. I would say that's not necessarily a homogeneous group. It's, some folks would be sent and to get home care because of medical or physical restrictions. They may not be able to transport themselves. They may be so severe that they have such low levels of carryover that they would really not benefit from outpatient therapy much at all. But also, I think what is happening too is sometimes when patients are discharged pretty quickly from inpatient, they're getting a few days, a few weeks, or kind of a stopgap level of home care before their outpatient rehab starts. So I kind of want to go through the various levels that we just talked about, talk a little bit about the advantages, disadvantages of cognitive rehabilitation in those levels of care, and then also talk about what I think are some good things to focus on in terms of your clinical work and your interventions. Acute inpatient, obviously the access to the patient is a major advantage. They are on the unit. You're able to, if for some reason you can't see them at a certain part of the day, or you miss them for a day, you can try to get in there the next day and adjust your schedule so that they are getting the rehab that they need. The other part is you have greater eyes on them in an inpatient facility. You're able to see them in between their sessions and on the unit, ambulating around the unit. And that is useful information to be able to see how they navigate and how they are acclimating to a new environment and how they're socializing and interacting with staff and other patients. The disadvantages are going to be that, obviously, like I said, it's a very short duration. It's hard to activate or implement any kind of true treatment because it's such a short period of time. A lot of times they're having medical conditions that may prohibit them from being in therapy. They may be, may have to be in bed, may have to be in the room, may not have too many hours that they can engage in therapy. And then what has been my experience is that when therapy is prioritized, PT usually rises to the top, OT rises to the top, and as a cognitive rehabilitation therapist, you're kind of low man on the totem pole. Deficits in arousal, orientation, and insight, I think, are gigantic when you're talking about it in acute inpatient and even subacute to some degree. Patients may be very lethargic with respect to orientation. If they're in any degree of post-traumatic amnesia, they're not encoding any information. So that's obviously hard for any carryover with therapy. And insight, whether it is just physiological anosognosia, where they're just not appreciating their deficits, or on a more of a psychological level of decreased insight, where they have not been able to really see the functional consequences of their deficits, so they're not aware of them. Spontaneous recovery is obviously not a negative; it's a positive for the patient. But with respect to, you have to be pretty nimble with your treatment, because somebody may be making progress from day to day within 24 hours. So it's a little bit of a moving target. I think the biggest things to focus on, at least what I believe, is monitoring progress with serial assessments, trying to get a good baseline, trying to give some measures that you can repeat day to day, or maybe once a week or once every few days, tests and exercises that don't have an inherent any practice effects. You want to monitor their progress, because if they are making progress, it dictates that they'll probably make future progress. So you want to be able to document that. Making good recommendations for future care, I think you could be very essential here in being able to say, look, we have some cognitive I think Dr. Rosenbaum alluded to it before, you may have somebody that's walking, you may have somebody that is physically capable, but they are not encoding information. They are unable to pay attention. They're unable to control their behavior and their emotions, and they have some major red flags for being discharged home. And that's something I think you can advocate on their behalf and maybe say, this is someone that absolutely needs to go to a step-down program in a subacute level facility. Last thing here I would say is co-treating too. It's something that we were encouraged to do when we were on the unit, and I think it's nice in that you can really, piggyback on some of the other therapies. Maybe go with the patient to physical therapy if they are having problems, if they're having behavioral outbursts, if they're having trouble kind of being in a very busy gym setting, and they might not be able to tolerate that. But if you're there, you can kind of work with them, you can help them keep track of their exercise routine. And those are legitimate cognitive interventions, especially if you know that you are doing them because of an inherent deficit that the patient has in attention and selective attention and things like that. And it obviously allows them to maximize the progress that they can make in PT in those early stages, which is critical. Subacute facility, next slide here. I think the biggest thing here, you have the ability to have cross-discipline goals within the infrastructure of most inpatient units. So acute inpatient, and then obviously subacute. You have speech therapists, occupational therapists, physical therapists, hopefully vocational therapists, physicians, neuropsychologists. You have the whole treatment team there. And hopefully you're able to not just have the patient get those services, but that the team is working in coordination. Sometimes it's led by the physician, sometimes it's led by a psychologist. It can be led, by various providers. But I think that when you are trying to have cross-discipline goals, when you're thinking of functional goals that the patient might have, you're able to really reinforce the techniques and reinforce the treatment across all those disciplines. And I think that is certainly helpful. You want to cater your goals, again, to daily living skills, independence, and safety. These are patients that still will be, transferring home at some point in the near future. You want to provide a lot of education to the family in the subacute phase. In my experience, families are a little bit more settled down. They've, kind of the dust is settled from the initial injury. They are more able to take in information about, the education on what the injury is, what the ramifications are going to be. And you should maximize that if you have access to the patient's family. And I think also too, here you have a patient that's subacute. They haven't gone home. They're certainly not back to work. They may be itching to go to work. And we obviously know cognitive functioning is a major predictor of whether somebody's going to be able to go back to work. This is where you might want to introduce the idea of saying, hey, look, there's these certain things that I think are going to be obstacles for you. We do not want you to rush back to work. We want you to talk to your employer. If short-term disability hasn't already been enacted, then it's time to do that. If you feel like a patient is going to struggle going back to work, the number one thing you don't want them to do that really sets back rehabilitation is having a patient go back to work when they're not ready. They may lose their job, they may be fired, they may lose their confidence, and it certainly set things back. So you want to, I think, to begin to broach that conversation with the patient and here. The next part I'll go to, this is probably one of the strongest recommendations for that came out of BIISIG. And this is really saying comprehensive, holistic neuropsychological rehabilitation is recommended during a post-acute. So I think that's just beyond acute inpatient. So it applies to subacute, it applies to outpatient, that it is recommended for traumatic injuries, non-traumatic injuries, so for strokes, regardless of severity and regardless of time post-injury. This is kind of the model. I think with brain injury, it's most important to treat holistically. I think there's probably a big trend, at least in the United States, that there's subspecialties and that people are treated, you have an arm person, you got a leg person, you got a heart person, and there's not too many people that are charged with treating the patient as a whole. It's extremely important in brain injury to do that, as I'm sure all of you know. Just a little bit of a graphical model here just to show the patient and around them all the things that are very much interrelated, the things that need to be part of a good comprehensive program. And it's not necessarily just having these. It is also that you have these and you have a good level of coordination and communication between these disciplines. I think that's essential. That's the difference between a comprehensive program and a comprehensive holistic program. Is the holistic piece. There's coordination of care, there's cross-discipline goals, and there's a consideration for the patient as a whole.
And I'd add to that also, which is often lacking, just the recognition of the importance of the psychological aspects of recovery, as well as the cognitive, emotional, educational pieces, which are often neglected even in programs that deem themselves as multidisciplinary or interdisciplinary.
Absolutely. And here too, so comprehensive outpatient programs, which is where I worked for the most part. For a few years, I got to work under Dr. Keith Cicerone, who's amazing, very prominent in brain injury and cognitive rehabilitation. And the program that he created there was amazing. It was collaboration with all disciplines. We were encouraged to have these cross-discipline goals, goals that really related. An example would be a patient that wanted to eat lunch at the staff cafeteria, the larger cafeteria, and he wanted to get his lunch and go outside and eat on the patio. And that was a goal. It was a self-driven goal of his, and was something that we were able to work on. PT was able to work with ambulation. OT was able to work a little bit with kind of the tray management and manual manipulation. Cognitive rehab worked on time management and making sure that he got out there and he was able to come back and be on to his next therapy on time. So the idea of cross-discipline goals, I think, are amazing because, again, you get the reinforcement from every angle. Here, there's also, speaks to what Dr. Rosenbaum was just saying, there's a greater insight at this point into treatment. I think patients have returned home. Patients have tried to resume their societal roles, their work roles, familial roles, and they have a little bit more insight. They have seen the functional consequences of their impairments play out. And while that's not necessarily a great thing that there's more emotional reactions, it does help in that it allows the patient really to be at a vulnerable time that they're able to work on and willing to work on those things. The disadvantages, I'd say, becoming a whole lot less common. I don't think there is as many comprehensive outpatient brain injury programs as there were in the past. That is mostly for managed care restrictions, and it's not something that is traditionally reimbursed or reimbursed at a high level or for an extended period of time. Excuse me. It's also something that is very time consuming for a patient. So if you have a patient that is trying to rush and get back to work, it's very difficult to do that if they're in one of these comprehensive outpatient programs. Is getting multidisciplinary therapies. They're probably there 3 to 5 days a week for a few hours each day. Metacognitive skill training, I'm sure you guys are aware of that. That becomes very important here because you want to generalize as much as possible. You want to make an impact on the patient. You want to remediate the skills and build the skills, but you also want to have them understand why they're building the skills, how it can be applicable in multiple areas of their life, how they can use compensations, how they can be self-aware so that they can monitor the success of the interventions and the failures and what they need to do different. So treating or teaching, I should say, metacognition is extremely important at this level. Again, addressing the psychosocial reactions and psychosocial ramifications that come up at this phase is important, and family involvement. So I see we are kind of like crunched for time. Do we, Brian, do you want me to kind of rush through a little bit, or we have the ability to go over a little bit?
Why don't you combine the individual outpatient and the those last two slides, since a lot of the challenges in home and community and individual outpatient are essentially the same, right?
Okay, yeah, no, I'll go through it. I'll explain what I mean by you're a unicorn. So it is basically, that's what I am a unicorn. That's what I'm doing now. I do cognitive rehabilitation as a private practitioner. There's not a lot of us that are not associated with hospitals or hospital systems that are doing this therapy in isolation. Again, part of it is that insurance doesn't really cover it, or if they do, they cover it at a low level. But I think you could feel fairly special, and that if you are giving this service to a patient, and if you were not, I should say that there's a possibility they might not be getting it elsewhere. At least in the United States, and at least in my kind of corner of the country, I'm seeing that there's not a ton of outpatient cognitive rehabilitation therapists. The disadvantages here, obviously, minimal access to communication and collaboration with other disciplines. That is very difficult. The things that I put below there are just really attempting to compensate for that void. So creating a network and community, knowing who, if you are a psychologist or a neuropsychologist, knowing the physical therapists that work with brain injury, occupational therapists, speech therapists, vocational rehabilitation services, knowing them so that you can give good, prudent referrals to your patients. Having the family come in and helping them kind of piggyback on what you're doing so they could transfer, therapeutic skills to the home setting. You really, in this case, I think we want to emphasize homework assignments, things that they can do between sessions. Going up to the second one, communicating, I would say, I always try to get 3 or 4 consents as soon as a patient comes in, especially if I'm just treating for cognitive rehabilitation and isolation. I want to say, give me your consent to speak with your primary care provider, another psychologist or somebody that you're speaking with, and try to get those consents and send your notes, and hopefully that will facilitate the other providers sending you notes so that you guys are, can kind of unify your treatment to a degree. So home care, again, representativeness, ecological validity. You're in the home setting, you're able to, the disadvantage is obviously short-term, not often covered, but if you are fortunate enough to be able to do cognitive rehabilitation, even a speech therapist, occupational therapist in the home setting, create the compensations directly in the home. You can probably focus less on just direct skill building and focus more on training on the tasks that they're going to be doing on a day-to-day basis. An example I give is, I always ask kind of patients, well, where's your workstation? What do you do? Well, let's come up with some compensation and some assistive equipment that you're going to use. You're going to have a timer on your desk. You're going to have drawers. You're going to have things organized. Visually, you're going to keep things in places that make sense. So if you are treating in the home, you're able to do that right there with them. The last 2 slides, besides the recap, these are just the BIISIC treatment setting specific recommendations. So they're all the recommendations, whether it's practice standard, guideline, or options from the BIISIC that make reference to whether it's applicable for post-acute rehabilitation or acute rehabilitation. So you guys will hopefully have access to the slides and you can look through those at a later point. And then the take homes, again, treatment setting is important. It influences how impairments manifest, how they could be addressed. There are trends to where we're starting to see from an outpatient provider standpoint, we're seeing more involved patients and more acute patients. Advantages and disadvantages to both. Try to maximize your advantages and try to do some cognitive rehabilitation and compensate for the disadvantages. And again, treating in isolation, if you find yourself in that situation, do everything you can to try to create a community around you. Know of other therapists and other ancillary services that you can refer your patients to. Maximize communication, maximize family involvement, and encourage the patient and the patient's family to be their advocate. So let them understand what brain injury is, let them understand what services are available and what they can do to try to get them.
Just putting that slide back up because somebody needed to see it.
Sure.
Okay, so that's that. Brian? I think now we would like to open the floor to some questions with Brian's help to mediate that. So if you could be patient for a second till he comes back on, that'd be great.
Yep, I'm here. Can you guys hear me?
Yes.
I can.
All right, yeah. Dr. Ganci, Dr. Rosenbaum, thank you so much for the presentation. We've got a little bit over, but as long as everybody's still hanging in there, I don't mind. If you guys have any questions, please let them. Please ask away. So, any questions from the audience?
Amy, I don't know if you could see him. I have a private chat now, kind of with Brian. I can't see any of the.
Yeah, you gotta there's a little.
Click over on the public tab.
And then you have to pull up that window. There's a gray bar that if you pull up, it expands the window.
I got it. Yep.
I see lots of thank yous. I don't see any specific questions. I'm curious for the audience, though, because this is something that, as we said, I understand that the system in other countries and other regions is quite different than what it is here. Is the system, the general system of care, as we've laid out, as far as our continuum of care, similar to what is in other countries, or are the models like majorly different than what we have here?
Maybe Dr. Ganci and Dr. Rosenbaum, you put your emails into the chat, and people could contact you with any questions they have. Here's a question. I lost it. How involved is the family in the rehab process?
Well,
you want to get that, Keith?
Well, I'll give you my piece. I mean, I think it obviously is case by case example. It's who are the supports. I think if you have a supportive family, I always felt like they were more from a cognitive rehabilitation provider. You were getting more access to them in subacute, and you were getting more access to one because they were visiting and they'd be there, and we also would routinely have family meetings. So I think. And we did that in the comprehensive outpatient brain injury unit, that family meetings were, I think, once a month. And that was a formal family meeting with the patient. And we would get feedback from the family. We would give them updates. And then it was also fairly routine for one or, maybe the spouse or a son or, a son or daughter or a parent to come into the therapy sessions occasionally as well. So I think it's up to the family, but it's certainly usually a welcomed part of the rehab process.
And I would add to that although it's not a formal BIISIG recommendation, the task force does strongly recommend that family be engaged in treatment. And it's more a matter of how you change the family's involvement throughout the course, as opposed to whether or not they should be involved. So early on, and as Dr. Ganci said, sometimes by the time they come to subacute, the family is sort of over that major hump. But as length of stays are getting shorter and more patients are entering subacute rehab still medically unstable, the family never had to sit down at the hospital level to discuss things like prognosis, goals, or anything like that. So I think in the early stage, there's a lot of need also for family support, interventions to provide education to them, to help them get on the page with us as the care team. Because again, for me, working in a more moderate to severe population, a lot of times, more times than not, the patient themselves does not appreciate the need for rehab, may not even appreciate where they are. And every time the family comes, there's a lot of begging to be taken home. And even when the family's not there, there may be attempts to escape the facility. And the family is tempted, especially in the case of like walkie-talkies, the people who are more physically able, the families don't also see the difference in the patient. And so it doesn't help when the family is sort of on the same side, so to speak, with the patient. So engaging them at that level. And then for training as well, when you're doing toilet transfers and ambulation and things like that in an inpatient facility, getting the family involved at that level so that they're not waiting until they're back at a community level program before they have any sense as to how to manage the family in the home. And one other thing that we do at our program is encourage, even while they're living inpatient, to go out on pass as often as possible, to try to visit the home with the patient or where they're going to be with the patient prior to discharge, so that we could troubleshoot problems that may occur once they do return to the home environment and help make that transition as smooth as possible.
Maria asks, I would like to know about how the rehab process may change when talking about children and not the adult population.
Well,
yeah, I mean, I worked at an inpatient pediatric brain injury program. Let's see on the changes. I mean, in a lot of ways, it's similar. I would say the one thing is, I think in place of cognitive rehabilitation is something more called kind of like academic development. Is that you're trying to keep the child or adolescent up to speed in school, and there's almost, whether it was called education therapy or tutoring, that seemed to kind of take the place of cognitive rehabilitation in some respect.
I think also the other piece of that is, and pediatric cog rehab is actually almost a totally separate domain, even though there's a lot of related factors. But the biggest difference is in implementation. And I think that there's a much stronger emphasis, and that there's a task force also within the ACRM, the pediatric task force, that is currently in the process of publishing a systematic review specific to pediatrics, and based on some other data that's already out there that does support treatments like attention process training and some of the metacognitive planning, executive functioning strategies are appropriate for children. But a key difference is often the intervention is provided in context. They are being pushed into classrooms. And so it's not as common to have this sort of prolonged comprehensive outpatient, because they want to get the students back into school, and they try to provide it in a contextualized manner through the school system, which is not how, unfortunately, it'd be nice if you can have a push in once you go back to work to help support you there. So I think that's one major distinction. The other being, again, that the family plays a much bigger role when you're dealing with children, and a lot of the training focuses on the family rather than necessarily directly to the children with pediatrics.
Mm-hmm.
All right. Pao asks, how can you make the patient take insight over his or her impairment? Which is the best procedure to achieve that goal?
So I think that that's sort of a bigger discussion, and the manual does a good job of sort of breaking that out. But ultimately, we view awareness impairments as being caused by one or multiple factors, the most simple factor of which is the patient was never educated as to what happened to them and what their impairment is. And so in that, it's more of an intellectual impairment or a lack of information, not necessarily a neurocognitive impairment where they're unable to see the problem. So in that simple case, it's a matter of providing them education, maybe doing some concrete tasks, functional tasks to show them how it's manifesting. It's a much bigger challenge, and there's much more specific protocols within the manual for patients who are truly neurocognitively unaware. In which case there's, depending on the psychological component, may involve an integrated approach between psychology, cog rehab, as well as the other treatment disciplines to try to do what we would call like predict, perform, have the patient sort of anticipate or make a prediction as to how they might perform on a task, and then sort of approach it in a scientific way that the therapist is working together with the patient as they explore together, rather than getting into this headbutting situation where the therapist is telling them you have this problem and the patient is just in complete denial of that. So, I mean, that conversation could be a lecture unto itself, but that's just a small snippet in a nutshell as to general approach.
And video recording is I think there's at least one or two recommendations in there for self-awareness of videoing
and verbal, specific video and verbal feedback. That is a practice standard. You're right.
Yeah. And that is, I've seen that be very influential, where patients just say, okay, I didn't realize that I was not making that level of eye contact. I didn't realize that I was, if it's for social pragmatics, really influential. Our speech therapists would do it in social communication groups, and they would tape the group, and then they were also seeing everybody individually, and they would see them individually and review the tape with the patient. And a lot of times it really kind of created a shift in their awareness to say, wow, I didn't realize that was kind of how I was engaging.
And I see, just to sort of not miss this question here, somebody asked about speech therapy interventions. And I think that For speech in particular, there are no concrete recommendations, but there are recommendations for apraxia strategy training, which are not in the first edition, but will be the second edition. And there's some nice protocols there for gestural training, as well as strategies that break down each stage of the action sequence where performance is a problem. And then also the chapter on social communication, which doesn't just address aphasia or those types of communication impairments, but does incorporate pragmatic skills training. And finally, it's about a lot of the being creative and incorporating a lot of the cognitive-based external strategies to help support. So one of the things that we do is for patients who have impulsive swallowing or unsafe swallowing, we'll literally write out the steps of a safe swallow. We might use that and keep it clipped next to their, next to where they eat, or on their lap tray if they have one. So just using those external cues, whether it's for increasing their intelligibility or remembering articulation strategies, just thinking of how you could use external supports, whether it's visual aids, whether it's pictures, the mirror for feedback during reteaching patients how to form words. Those are all strategies that are not directly for speech, but apply because it is the application of the cognitive strategies to the speech practice.
All right. Thank you so much. I think we should wrap this up. We're about an hour 20 in. Thank you everybody so much for attending. Dr. Rosenbaum and Ganci, if you want to put your emails in the chat I believe you guys are more than happy to have people ask you questions.
Sure.
They're very much this is a very international audience, and I appreciate you all. We're here all weird hours of the night. It's 11 o'clock where I'm at. But yeah, if you guys want to continue the conversation, feel free to write to myself, Brian. I'll put my own email as well.
Great. I just put it in there too.
And did they pop through? Mm-hmm. All right. Yep. So you guys have both Dr. Ganci and Dr. Rosenbaum's email, and my own as well. If you guys have any questions, please feel free to write any three of us. If you write me, I'm happy to forward the messages on over to them. I'm going to leave in the chat. We have in June, we have Dr. Christine Kingsley. Will be presenting her presentation called Emotional Regulation and Acquired Brain Injury, an overview of evidence-based intervention models for dysexecutive problems. You can click on those links to read more about the next presentation or to sign up for it directly. And thank you everybody. Thank you, Dr. Rosenbaum. Thank you, Dr. Ganci. It's been a pleasure.
Great, thank you.
Thank you all.
Thank you for hosting.
Yep, and have a wonderful afternoon, evening, morning, and I hope to see you guys at the next NeuronUP Academy.
Great, take care.
Take care, bye-bye.